Hello, and welcome to the Vestibular Disorders Association, Making Vestibular Visible. My name is Dr. Kathleen Strauss, and I'm joined by Rochelle Lazon, and we are neurological and vestibular physical therapists and volunteers with VITA. Our presentation today can be enjoyed both as an audio podcast and a video, but I do want to let you know that today, if you're listening to the podcast, that there are going to be some helpful slides that may bring to light this revolutionary science of these fixational eye movements. We're going to look today at how understanding eye movements plays a critical role in stabilizing vision during head movements that influences balance and helps us maintain clear vision. We'll be introduced to a novel retinal-based eye tracking technology that has unlocked the ability to see the unseen eye movements underlying many patients who have normal examinations using pupil tracking devices, and why studying different ocular structures for eye tracking may elicit different results. The discussion today will highlight how small deficits in oculomotor control, such as impaired fixational stability, can exacerbate vestibular dysfunction and affect rehab outcomes. So today's educational event is brought to you by Retitrack. And we're honored to be speaking with Dr. Jacqueline Thais, and she's the Chief Medical Officer of Sea Light Technologies, as well as a practicing optometrist, clinical researcher, international lecturer, and author. Welcome, Dr. Thais. We're excited to have you here today.
Thank you.
So today we have a variety of people in the audience, and we have people who have diagnosed vestibular conditions, some with vestibular symptoms, and others are healthcare practitioners. Help us understand what you're going to be talking about today, and how the eye movements and the eyes affect the visual system. The vestibular system.
Yeah. So what we're going to talk about today is a little bit of a combination of multiple types of eye movements. So I'm a practicing clinician as well as the chief medical officer for Sea Light. And so the neat thing is being able to see both from a clinical perspective how patients might present with some disorders of eye movements and the symptoms they may have that can overlap with vestibular symptoms or be concomitant with people who also have vestibular symptoms or conditions, and then going also into the science of eye movements. And the cool thing about eye movements is now that technology is changing and we're able to see smaller and smaller things using diagnostic devices, we're getting to know a lot more about eye movements than we ever did before. And so I'm excited to talk a lot today about fixational eye movements, which most people don't think about fixation being a movement. We think of it as steady. And so it'll be neat to kind of deep dive into that eye movement.
Absolutely. What is oscillopsia?
Yeah, so oscillopsia is a complicated terminology, but essentially it is the perception of the environment moving or bouncing around when it actually isn't. And so when people have unstable eye movements, they can essentially feel like the world is moving, but it's not like vertigo. When patients complain of vertigo, when there's a crystal loose in the ear, that's more the world is spinning around me or I'm spinning. When people have oscillopsia, it's more like pulsation, like the world is pulsing at me a little bit or hovering, or especially if you look at really small things, they'll maybe notice it's jiggling side to side, but it's not spinny. And I think that's really important when we're looking at trying to diagnose or differentially diagnose conditions that impact the vestibular system, is what exactly is unstable about the eye movements. And that oscillopsia, or the perception of movement, it can happen with just some objects, or it could be the entire visual field. And this can happen when the patient is stable or when they're walking or moving their head, depending on which eye movement is doing it.
Well, I know you came today with an amazing slide deck that's going to help us talk about the topic a little further. You ready for me to get that started, and we'll take a look at some of these things?
Yeah, that'd be great.
Okay.
So we will start with the next slide. So today we're going to talk about mostly fixational eye movements. I always like to start my slides by thanking the people who got me here. So for C-Light Technologies, we have Christy Sheehy as our CEO and co-founder, and then Joe, who is our CTO and co-founder of the company. And I would be nowhere without them, especially when it comes to understanding the tech behind everything that we'll get to at the end of the talk. So I'm just very honored to be able to work with them every day. So next slide. So unfortunately, we found out right before we started this that none of our videos are working. So what we're going to do is we're going to kind of put a link online on our website, clighttechnologies.com, so that you can see some of the videos from the slides. So we'll just put that probably posted later on, probably by next week, so that people can see the videos, because I think the videos are really helpful at understanding, like for this one, it shows what pulsation means for oscillopsia. And so we just wanted to kind of show that to people. But we already kind of talked about this, so we can go to the next slide.
Okay. Are those videos on the website? Because we can direct people there. Not that they're going to look at them right now, but we certainly can direct them to. And I think we can probably get those links in the comments below. So those will show up.
So we'll put them in the website for sure. And we'll just post them on like a talk for follow-up.
Okay.
So I know one of the big questions that people are wondering is, why is an optometrist on the Vestibular podcast, right? But I think a lot of people don't know. I know physical therapists know for sure, and ENTs as well, but there's a lot to do with the visual system and balance and the vestibular system. And so when we think about what contributes to how we know where we are in space, it's really the big three, right? Where I see where I am in space, my ears give my head feedback about where my body and my head is in space. And then my neck, which hosts a whole lot of proprioceptors, as well as some other muscles and joints throughout the body, also gives feedback to the brain about where we are in space. And so when we feel balanced, all three of these are kind of working together. And usually some people have one preference over more than another. So some people are more visually dependent for their balance, some are more vestibular dependent. And I always say, for the most part, if one of them goes awry, you can kind of get by, but then you lean on the others. And so sometimes, when does vision become really important? Well, maybe somebody doesn't have glasses, and you'll see these patients where they're like, oh, my glasses made me feel so much more balanced. And it might be because, or made my balance worse, if your vestibular system is impacted with some type of dysfunction and you're relying more on your visual system, then you're going to be more sensitive to changes in your glasses or more sensitive to things like that. So when you're wearing glasses like progressives that make things a little blurry, getting out of progressives will make your vestibular symptoms a little better. It's not going to fix your vestibular disorder, but it'll allow you to depend more on your visual system for feedback. So the three systems really work really well together. And I always say, having one out is bad, but two or three, which can happen when you've had a concussion, is really hard, because you can get a neck injury, ocular motor problems or eye movement problems, and vestibular problems. And so then it's really hard to feel kind of balanced and in space.
Yeah, and to reiterate, this is why diagnosing and treating vestibular symptoms is complicated and requires a multidisciplinary approach because of these three systems and the complex interaction of them, and then processing in the brain. So it takes an army sometimes to get it all sorted out and then figure out the best plan.
Yeah. And then the other thing I think that's difficult for all of us is patients don't normally come in with oscillopsia complaints. They usually always come in complaining of dizziness. And the hard part for clinicians is trying to tease out, what does dizzy really mean? And I always say the first thing I always have to figure out is it spinning or is it floaty? And really try to get patients to describe it better, because that's really helpful for the clinician to be able to figure out what it is. And then what triggers it and when. So for example, when we have eye movement dysfunction, oscillopsia can happen with a condition called nystagmus, where you get rhythmic movement of the eyes. And if there's a kind of rhythmic movement dysfunction coming centrally from the brain, well, then both eyes are going to be rhythmically moving. But I have found that with conditions like BPPV, I might have a patient where when I'm doing visual acuity testing, they only have that oscillopsia or movement of letters with one eye only on the side of the BPPV. So kind of looking at, do we have the movement with one eye only or both eyes? And are the movements symmetric with each other, or are they different? And that can help clinicians try to kind of figure out what's causing it. And of course, depending, on what's causing someone's oscillopsia, that can also make it harder because some people can have multiple things causing, right? You can have multiple canals in BPPV, or you can have a very large brainstem stroke, which can cause a multiplanar nystagmus to make the perception feel off. But I find that from a visual perspective, it's really helpful if people tell me it's pulsing or shaking side to side for me to know if it's kind of a visually driven oscillopsia versus the spinning that you'll get sometimes.
So to simplify for patients listening, do you talked about asking people to describe what they're feeling without saying the word dizzy, and that's true. Does it help lead you to say, do you feel like you're moving or that the room or the environment is moving around you? Because this is a sensation of self-movement or a perception of environmental movement. Would that be accurate? And just coaching the patients to try to understand, do you feel like you're moving, bouncing, turning, or do you feel like the room or things around you are bouncing, turning, or shifting or drifting? Is that right?
Exactly. And then, when is it happening? Is it all of the time? Does it last for the whole time? Is it constant? And when you dig into it, there's some people who have multiple types, and they'll be like, well, when I move side to side, I get this type. But then when I'm just sitting and reading a book, I get this other type. And again, people can have more than one thing, especially with traumatic brain injury causing oscillopsia. So trying to figure that out for them is difficult to do, but once you figure it out, super helpful.
Absolutely. I'm reminding people in the world of vestibular disorders, while we have all kinds of nice technology, our story still really, really tells us a lot of information. So the story is important even when in the midst of you having this great technology.
Yep. So what I really like to think about when we think about oscillopsia is, for whatever reason, we're having unstable vision. That can be caused by multiple deficits. And so in this vestibular cohort that's listening to this podcast, a lot of physical therapists, I think, when you're a hammer is going to see a nail. So from a vestibular perspective, you're always going to think it's vestibular. And it can be central vestibular, or it can be vestibular ocular reflex dysfunction, meaning the dysfunction is between the coordination of the vestibular and visual components, or it can be peripheral vestibular. And you can also have issues with the neural integrator, where it's central disorder more for central kind of ocular motor dysfunction, or it can be fixational dysfunction. So we can have different types of ocular motor dysfunction causing ocular instability. So next slide. And eye movements are complicated. And so I always like to start my lectures by asking people to think a little bit about why we would even need eye movements. Because if you think about it, our heads move on our neck and our body moves. So what is the purpose of eye movements? And why do they need to move at all? And next slide. And the reason that they need to move actually has to do with the retina. So in the very back, the slide that's shown here for those of you listening, is the inside of the eye. So when you go to an eye doctor and we dilate your eyes and we look inside, this is actually a part of what we see. So the orange looking donut is the optic nerve. So we can take a look at your optic nerve and you can see the blood vessels coming out of it. And then a couple kind of in the dead center of the picture, you'll see I circled it, but we call that area the macula. And in that area is a very high density of cone photoreceptors. And because of our anatomy, that really high density of photoreceptors there allows us to be 20/20. And so the whole reason that we have eye movements is so that we can point our fovea at things so that we see 20/20. And so if the image or my eyes aren't looking at something perfectly and it falls off of the fovea, then the patient's going to have blur. And that's important because sometimes people are going to the eye doctor because they have blurry vision, and it's blurry because they have ocular instability from their vestibular dysfunction. And it's driving the provider crazy because the patient's 20/20, but the patient's like, no, it's blurry. And they're like, but you see 20/20. Frustrating for everyone because it's kind of miscommunication. But also it's frustrating for the patient because there's a difference between being crisp 20/20, I see clearly, and this kind of like, I see 20/20, but it's kind of got fuzzy edges around it, or it's moving, but again, subtle movement is often interpreted as blur. And so kind of something to keep in mind. The other thing to recognize is it's kind of chicken or the egg. So if we have trouble with ocular instability, we're going to get blurry vision. But if we get blurry vision, we will also get ocular instability. And so people, when they get things like macular degeneration, where they end up losing some of their vision, they're going to have anomalous eye movements because the drive or the need to move the eyes perfectly goes down, because no matter where they point the eye, they're going to see the same. And so the brain doesn't have as pristine of eye movements when people have vision loss from retinal or optic nerve disorders. And so if you're doing eye movement testing and you have a patient who has vision loss, do keep in mind that they probably won't have normal eye movements, especially in the eye with vision loss. And that can, especially if they've had the condition for a very long time. And you can rehab it until you're blue in the face, and it's never going to get better because the driver for getting accurate eye movements is gone, because they see 2200, whether they use their fovea or they use their peripheral retina. So that eye will be a drifting eye. And so it's always important, if you have a patient, when you're doing kind of eye movement testing with them, or trying to kind of work with visual stability, if you can't get it, or they're just not responding, or their blur is not getting better, that you refer for an eye exam, because people can have other conditions causing their blur. Even if they got a brain injury, you can get, damage to the macula when you get hit in the head and get a macular hole or macular edema from the injury itself. And then that's why their eye movements aren't getting better. And again, the hard part is for the patient, symptoms are the same. I'm dizzy and blurry. So my big thing for people is, referring to just make sure everything's okay. And if everything is okay in the back, most likely it's ocular instability.
Wow. Jacqueline, if I could just interject for 1 second, we've had a couple of questions in the chat asking if oscillopsia, I am so sorry, oscillopsia is related or similar to NOVD, or neuroocular vestibular disease.
How would you define neuroocular vestibular disease? Because that's not a term that would be used consistently in eye care. It wouldn't be a diagnosis or a CPT code that we use.
I think a central midbrain lesion, according to this comment. She says similar to NOVD in the midbrain.
Yes. So if you have a midbrain lesion that can cause impaired eye movements, you will get visual symptoms of oscillopsia if you get nystagmus or something impacting your eye movements that control stability.
Okay. Great.
All right. So next slide. So the big thing to recognize, because I think this is a big one in our clinic that we'll get, is, why then the eyes are at the front of my head and I have an ear problem or I have a brainstem problem. How are my eyes impacted? And what you have to recognize is that the brain has dedicated over 50% of its tissue to controlling eye movements. So every single lobe of the brain is somehow involved in eye movements. The brainstem, the cerebellum, the midbrain. And so when people get a lesion in that area, or they have any type of, whether it's a stroke or they have inflammation or an infection, there is potential that you can have damage or impact to the ocular motor system. And so next slide, the eye movements that we have one called vergences. And so vergences is a type of eye movement where I'm looking up close and then I look far away and they uncross. So that's called divergence. And then when I'm looking far away and I look up close, the eyes cross, and that's convergence. So that's what vergences do. They move our eyes backwards and forwards. If I'm looking at something that's ahead of me and it's moving slowly across the screen, or imagine like a soccer ball moving slowly in front of you, you're going to track that soccer ball with both eyes at the same time, left to right. That is called a smooth pursuit. And so you are looking at it and following it with your eyes. If, however, you're following that soccer ball with your eyes and you decide you want to move your eyes from the eyes, let's say to the goalie, so you're jumping your eyes from point A to point B, that would be a saccade or a saccade. So you're making a big eye movement from one target to another. If you are moving your eyes and your head at the same time, the vestibular ocular reflex is important. So what it does is essentially when the ears sense head movement, the ears tell the eyes to stay stable or move in essentially the opposite direction at the same speed so that the image appears stable even though you're moving in space. If you use your vestibular ocular reflex for long enough, eventually the optokinetic reflex will take over to allow you to feel stable while you're moving or in motion. So if you're sitting in your car for a long period of time, the OKN is going to take over. And then the one that I want to talk about the most today is actually fixation. So when you're looking at something, like you're looking at your computer or you're looking at your phone right now, while it looks stable and you feel like your eyes are completely stable on the phone, your eyes are actually microscopically moving all of the time. And we call those fixational eye movements. And so they look steady, but they're not. And there's 3 types of fixational eye movements we're going to get into today. Next slide. So the big thing about fixation is that we spend all of our lives fixating our gaze, and it's never static. They're never still. And so when people have fixational eye movement abnormalities, the problem is that sometimes clinically, without a diagnostic device, we're not going to be able to see it. And so the frustrating thing for these patients is that they're going to come in and be like, the world is moving or shimmering. And we look at them and we're like, you look fine. So it feels like we're gaslighting our patients. But the problem is clinically, from our eyes, I can't see microscopic movement.
Right.
So you need to use a technology to be able to see it. And I know with physical therapists, sometimes when you guys are looking for nystagmus with head positions and you guys use a lot of pupil trackers, same thing, of some of the eye movements, you just can't see it without those goggles on. And it's not the bad on the clinician, it's just the limit of human vision in assessing eye movements.
It probably makes people feel better for you to say, well, they are microscopically moving. We just can't see it with our naked eye, but now we have technology that can, because I think that, yeah, when it was named fixation, people were probably convinced they weren't moving, but now we know they are.
Wait
Right?
a second, they're moving. So yeah. So next slide. So why do they move? The reason that they move is so that the brain doesn't neurally adapt to your visual signal. So what is neural adaptation? I like to use smell for a great example because the brain neurally adapts to smell all the time. So pretend that you get into an elevator and there's someone that walks in with just a horrendous amount of perfume. And initially, it just really gets you as far as how strong the smell is. And then as you're in that elevator with them longer, the smell kind of goes away. But it's not that it goes away. It's that your brain recognized that the smell is not a threat and it stopped paying attention to the signal. And so it kind of goes away for your brain as far as a signal. But for vision, if you were reading, a text message on your phone and your brain adapted to the signal, it would essentially fade. And so this is a really cool way to see visual fading. So if you look at the very center blue dot, I always say look at the white dot within the blue dot and hold your eyes there as steady as you can. What you'll notice is that the peripheral circle starts to fade away. And that is what visual fading is. So your brain is actually neurally getting adapted to that peripheral signal. If you move your central fixation to the peripheral circle, it bounces back. We call this the Troxler fading effect. But essentially, that's why your center vision will never fade away, but your peripheral vision can sometimes neurally adapt, but your central fixation should not, if fixational movements are working. And so again, the point of these movements is to constantly make microscopic motion so that the brain is always getting a little bit of a new signal so that it doesn't ignore your vision and turn the signal off. Now, the problem, though, is that fixational eye movements are kind of the Goldilocks of eye movements. So you don't want them to go too slow or your vision fades. But if they go too fast or they're too big, then we get blurry vision. And so when people, and this is the most common thing that can happen, is when people have fixational eye movement abnormalities where they're making too many of them, then they're going to get blurred vision or unstable vision. And so the goal, and that's kind of why it's such a hard eye movement, the brain has to be so precise with it of, I need to move enough to not adapt, but not so much I don't see perfectly. And so it has to really, that perfection in order to maintain a clear single space for people. I don't think we give enough credit to how much the brain is constantly adjusting to make sure that we do that.
Are we looking at FEMs to be single eye or monocular or binocular, symmetrical or asymmetrical, or is that, are you going to get there?
Great question. I will get there because there's actually 3 different fixational eye movements, and some of them are symmetrical and some of them are not. And we're still learning a lot about them too.
Yeah.
So, and again, this is one of those things where I wish our videos would work, but the big thing I like to hit home for people is when I clinically look at people and they have fixational eye movement abnormalities, sometimes I'll see a blatant nystagmus, and that will be diagnosed by most clinicians. But there's a lot of people where we look at patients, even on a high mag microscope in office, in an optometry or an ophthalmology office, and clinically, I don't see any movement. But microscopically, you're going to see some very small movement. So the video that's on the right is a zoomed in video of photoreceptors. And when you go to our website, you'll see some of these fixational movements. And so they're tiny, they're itty bitty little oscillations of photoreceptors. And a human being's not going to be able to see them on their own. Mm-hmm. So next slide. So this is one of them. So there's 3 types of movements for the clinicians out there. So there's microsaccades or microsaccades, and these, just like regular saccades, are jerky. And so they essentially are going to be the cause of retinal slippage. So they're there to help prevent some of that neural adaptation. They're about 26 minutes of arc in size, which is about 100 photoreceptors. So again, absolutely tiny. They're thought to be somewhat yoked together. But again, there's a couple of articles that say they are and some that say they aren't. So it's a little frustrating as far as, is it one-eyed or two-eyed? But they should be decently symmetrical to each other. Next slide. So the next one is tremor. So this is like a very, very small wave-like motion that occurs in between these little jerks. And again, think of it, it's kind of Brownian motion, right? It's a little bit random. It's not always perfect. And so if you look at the graph on the right, you can see that there's some kind of big red stairs, kind of like plateaus going up and down. That would be a rhythmic movement that would be abnormal, because in these eye movements, they should be small, but they shouldn't be perfectly rhythmic like a nystagmus in a normal fixation pattern. In an abnormal fixation pattern, when somebody has something wrong that's causing them to have very microscopic nystagmus, then we'll be able to see these trends and see these saccadic movements. And then last one. So the last movement is drift. And so drift is essentially a smooth pursuit movement. So think of it as your brain is going to make your eyes saccade away from what you're looking at, and then you drift back. So you're kind of always going between drift and saccade back and forth. And so the cool thing about microsaccades and fixational eye movements is that the pathophysiology overlaps not just saccades, but also smooth pursuits. And so I didn't go into it too much, but every eye movement uses a different part of the brain. So when somebody has something wrong in their brain, you can have an impact with one eye movement, but not the other. And even just going to the right is different than going to the left. And so the cool thing about fixational eye movements is just the vast territory that they would encompass, because it is just a very neat way to look at it as a biomarker.
So relate this drift and the compensatory saccade to spontaneous nystagmus that you might see in a vestibular patient, acute vestibular injury.
Sure. Yeah. So let's see. That's kind of, so think of it when you guys get, I think a lot of times when you guys are looking for BPPV, you'll see kind of an end gaze nystagmus where it jerks to one side and then drifts back, jerks and drifts, jerks and drifts. That would be similar. It's just on a much bigger scale. Whereas fixational micronystagmus, and these ones, right, are on purpose. We want our eyes to be moving a tiny amount in order to keep our vision and our visual signal working. And then when they get abnormal is when we start to get nystagmus, and as it gets bigger and bigger, you then end up being able to see it. And in fixational nystagmus, it would be something that's not necessarily a gaze-related issue like it would be with vestibular. When you guys are moving them in different head positions, it would be more while I'm looking at something with my head stable, not moving, not turning, then I'm having a nystagmus. And again, just kind of differentiating that a little bit. Mm-hmm. And the big thing I like to always tell people is, I know they sound similar because of the terminology, but microsaccades that we use for fixation are not the same thing as macro or bigger saccades that we do testing for. And so when I'm in office and I'm having patients look from one finger to another, back and forth, that is a voluntary saccade. The brain is, and the patient is deciding to move their eyes from point A to point B, whereas microsaccades are involuntary. They're not able to cognitively really control them. Macrosaccades are clinically visible. I can do it in office with myself and be able to see if they're accurate or not, whereas microsaccades are microscopic. You're not going to be able to see them without a device. And then the point of saccades are different. So the point of a saccade is for me to move my vision and explore my world from one object to another, and they're big. They're bigger than about 2 degrees in movement. A microsaccade is less than 2 degrees in movement, and the whole point, right, is to be able to see. So again, with a macrosaccade, I'm moving my vision, and with a microsaccade, the point is to prevent neural adaptation. And to do this, the cool thing that they're still learning about is the pathophysiology seems to be similar. So we think that they have similar generators, but again, they have different purposes. So even though they use the same territories in the brain, they may not necessarily have the exact same pathway, but they use overlapping neurons, which is pretty cool. And so there's never going to be a quiz on this, but I created this diagram a long time ago because it's so cool to look at all of the structures in the brain that are involved in moving your eyes. So literally every single this is just the pathway for saccades. It's not even for smooth pursuits or vergences. And you can see that every single lobe of the brain has a purpose. And the purpose is different. So one part of the brain is going to be for telling you where to move the eye. The other one's going to be for how big do you move it and how fast do you move it? And then once you move it, do you keep the eye there? And that's kind of how the brain does it. And we take for granted how much our brain does in the background for eye movements until you lose the ability to do it. And then you really start to notice it. I know that with our patients for sure, as they start to recognize, man, I didn't realize how much my eyes helped me out before.
That's a great slide. Flocculus and colliculus and all of that. It sounds like Italian pasta night, but it's not. It's your brain. It's great.
Yep. Yeah.
It's amazing.
And then, so next slide. So as far as fixational eye movements go, I know one of my big questions is why have I never heard of them before, especially as a clinician or any physicians on the call? Why have I never heard of them before? And even in optometry school, that I did over a decade ago, no one really talked about it very much. And the reason is because historically, we initially identified them in the 1950s, and there was a lot of research from the 1950s to the 1970s. And then because of the technology in the 1970s, there was this huge debate in the literature as far as, do these eye movements really exist? Or is this just an artifact in our measurements? Because, our equipment is shaky, and they just had this big argument and it just kind of petered out. And so people didn't really look at fixational eye movements for decades. And then in the 1990s, we started getting some really great technology, right? We got infrared tracking, we got laser-based tracking, we have retinal tracking now. And so now we're able to see invisible things that we couldn't see before. And now there's this huge interest in fixational eye movements because of all the eye movements, it's the most involuntary one. And so if you're going to look at something that, I want something that is microscopic to track disease and things like that, you want one that the patient can't influence. And that won't be influenced by the patient's cognition. So our cognition, how much I slept last night, how stressed I am, can impact how well I do on eye movement testing if it's a voluntary eye movement. And so fixational eye movement research right now is super cool for that reason of it's purely involuntary. It's got a very wide net of pathophysiology. And so it's kind of seeing the unseen that we've been missing for so long. So it'll be neat to see where it goes.
Absolutely.
And then just to give people a reference of how small things are. So again, when I was talking about, tremor is an eye movement that's a couple of photoreceptors big. A photoreceptor is about 2 microns. To keep that in mind, the diameter of a hair cell is 70 microns. So to give you how small these eye movements are is they are a fraction of a hair. So we're not going to be able to see them on our own. And then next slide. And that kind of comes to what's exciting at Sea Light. And so our CEO, Christy, he actually invented the device. And so what it is essentially is it is FDA cleared, 510K cleared. And what it does is it takes very high resolution videos of the photoreceptors. And most diagnostic devices, what they do when we look at the retina and eye care is they try to take the motion out of the image to get a really good image. But the problem is that motion is what we're trying to track. And so what Christy has done, and you can go to the next slide, is she has essentially created a device where a patient can put their face in undilated, and they take 3 10-second scans. And we just take a video of your eye, and then using software and AI, we essentially look at how the eye moved over that 10 seconds, and we can map it over time. And the cool thing then is you get a graph. And I always say for people who work in nystagmus, and I have a vestibular or a vestibular neuro PT in my clinic, and she has the Frenzel goggles, and the number of times that we're trying to look at a video of the nystagmus and try and figure out the pattern, and how much I love that this device maps it out. It's so much easier to see a pattern, especially in multiplanar, because I've seen a couple of images where somebody has maybe an upbeat vertical nystagmus, but then a pendular horizontal. And so to me, it looks hard as a clinician to stratify it. But then once we look at the graph, you're like, oh, that's all that is, because you can see the pattern when it's graphed out. So that to me is one of the coolest things about the Retitrack, is you're able to see microscopic eye movements that you wouldn't see any other way. And the technology not only just captures it on video, but it also synthesizes the motion to tell you how accurate was it, how fast was it. And so you can think about the granularity of, if you're doing a treatment, when I see a patient and their eyes are wiggling, and then I do something, maybe their eyes are wiggling less, but the problem is my biomarkers, well, they're still wiggling, right? And so it's hard to see sometimes granular tracking of, am I doing anything to make the patient better? And we're relying a lot on how the patient feels. So we're just having them tell me, are you better? And the problem with that is if their complaint is oscillopsia, or their complaint is dizziness or lightheadedness, maybe they previously were an 8 dizzy and now they're a 6 dizzy, but dizzy is dizzy. And so it is hard sometimes to see if you're making any impact without having that granularity. And so that's where I think having that combination with data is so exciting for all of us that are clinicians, because all of us have just been really struggling to do what we can for our patients, but without the technology to do it. And so we're relying a lot on patient feedback, which again can be variable, even to the patient's best try. But again, just, not sleeping well is going to make you feel different about your symptoms than if we just have a solid device. So it's pretty exciting.
So for vestibular rehab therapists who might be watching and they're used to doing things like dynamic visual acuity, would an improvement, would that test measure or be sensitive to an improvement in fixational eye movements, like a dynamic visual acuity test?
Yeah. So where you're going to really notice fixational eye movements in particular is going to be on static visual acuity. And so I always tell people, when you're doing dynamic visual acuity, you need to do static visual acuity first. And it's funny how different professions do things differently, but norms in eye care for static visual acuity is you should be able to have a dynamic visual acuity of 1 or 2. Usually it's around 1 row difference. So if I'm 20/20 visual acuity, then I should be 20/25 dynamic or better. And I've had other people who are like, 20/40 is okay. I'm like, no, it should be only within about 1 line difference. But you can imagine if I have fixational eye movement problems, so that I'm also just unstable if my head is static. If you're unstable with your head static and now you're moving your head, that instability is going to be a whirlwind for people. And so being able to fix fixational instability can help with that dynamic instability, especially if for people who've done VOR training and you're just trying to get that dynamic visual acuity better. If you don't fix the ocular motor problem, you can try the vestibular rehab as much as you want, but the ocular motor problem is not going to rehab with vestibular rehab necessarily. And then you have to fix the fixation a little bit so that
that's why it's important. Fix the ocular motor problem first. That's right.
Yeah.
Mm-hmm.
Yeah. Although I will say chicken and the egg, there are some patients that I've had where I try to fix the ocular motor. I'm like, no, we got to send you. I always say, so fix the peripheral vestibular problem first, then fix the ocular motor problem, then send them back for the central vestibular problem. So that's how we've found it in ours is if they have a peripheral vestibular disorder, it makes it really hard to do the ocular motor. So I always start, we flop them back and forth in our clinic sometimes.
That's good.
So yeah. So again, the cool thing about this machine is that it is tabletop device. In order to get microscopic eye movements, you do have to have a very stable patient. And so we have a proprietary state-of-the-art head-mounted design for the patient to put their face in. Obviously, it's not going to be the same as some of the other techniques that are used in clinics and vestibular clinics like Fresnel goggles, where you're throwing the patient down and bringing them up. But it will be able to give you some data that you maybe won't have on their fixation stability. And then it's easy to control, 10-second scans. You don't have to dilate to do it. So it's pretty easy to do. And then the target that they're looking at is just a red square. And so you can do it through people's contact lenses or their glasses or take it off. The big thing is they just need to see it. So if they're very, very farsighted or nearsighted, they might need their correction. If they're wearing their contacts, they can keep wearing their contacts. But usually we have people just take their glasses off and you just focus in on the retina and then click the button and it takes the scan. So for this one, since we don't have the video, we'll switch to the next one. But the big thing that this is something that Joe and I were looking at, because we had this question when we were looking at this technology originally, which was, what is the difference between using the pupil to track the eye movements versus using the retina? And do we really need to look at, so essentially think of it as the pupil itself is a very dynamic structure. It is constantly moving. And if you're using a constantly moving target to be able to track a moving eye movement, then inherently there's going to be some discrepancies in actual motion versus artifact. And so what we did is the cool thing about our device is we have a retinal camera, but we also have a pupil tracker. And so you can do both at the same time. So we're not comparing devices. We're just looking at if you use the pupil versus the retina, which one's more accurate. And we were very impressed actually with the pupil up to about 2 degrees. So up until about 2 degrees, the pupil tracker did a pretty good job of identifying fixational eye movements and saccades. We used the saccade test for this one, as well as the retina, and we were pretty impressed. But once we got below 2 degrees, especially 1 degree and below, is when we really started to notice that the pupil just was not able to accurately detect the motion. And so in general, the pupil might not be the best target. And so we really do need the retina to be able to see accurately fixational eye movement dysfunction. And so it's kind of one of those, when you get bigger movements, it can be harder, like 40-degree saccades. It'll probably be easier to use the pupil because that's a giant movement. But if we're looking for microscopic eye movements, this was kind of the study that we looked at to say, well, how small does it need to be? And since we know that microsaccades, which is the biggest eye movement of fixational eye movements, is about 1 to 2 degrees, then you'll need the retina to be able to find them, essentially. So I know a lot of people, if you have the goggles, are like, I'm going to look at fixation now with my goggles. But you're probably not going to see any eye movements with them because the pupil is just not going to be able to see it. Mm-hmm. So, and that was kind of what we have here is, there's beauty in both, I think, in both types of eye tracking, because you're looking for different types of eye movements. When you're looking at those pupil trackers and the Fresnel goggles for people who use them in the vestibular realm, you're looking for large eye movement changes with positional changes. Versus I'm looking for a microscopic change in somebody who's not moving their head or their eyes at all, right? And so you just need a different structure to be able to do it.
So when we went from electrodes around the eyes to infrared camera pupil tracking goggles, we were able to see for the first time torsional eye movements. I see Yes. You're recording horizontal and vertical. Do you foresee that there are there fixational eye movements that are torsional? And do you think that you will one day measure them?
Yeah. So pathophysiologically, there is not a pathway for a torsional eye movement. So pathophysiologically, we have eye movement, we have neuropathophysiology for horizontal motion and for vertical motion. And there's a couple for torsional when it comes to, I think there's a rotary signal. But a lot of the times when you're seeing a rotary movement, it's because of a dysfunction in both horizontal and vertical meridians, and it's rhythmic, and so it looks torsional, but it's actually a deficit in horizontal and vertical components. And so pathophysiologically, we look more horizontal and vertical, but again, you have to keep in mind that even though we're tracking it in horizontal and vertical, for the patient, it's happening spontaneously. So if it's moving, we all hate math, right? But if you go back to math and we think about geometry and I'm moving on a vector horizontally and vertically, you'll be making a diagonal movement. So you'll be able to, I think that's what actually makes it even cooler is when you see a rotary movement to see it in a horizontal vertical plane and see which plane is actually worse. And because that for me has been the most interesting is looking at what the graph says. And then I look back at the video and I'm like, oh, I can kind of see that now. So, but yeah. And then, because the only muscle that turns, we have from an ocular motor perspective, we have 6 eye muscles. And there are 2 eye movement muscles, the superior and inferior obliques that will rotate the eye when that muscle fires. So you can get rotary movement if that muscle, like in superior oblique myokymia, where that muscle is overfiring and it's kind of torting the muscle. But that's not going to be necessarily like neurologically driven rhythmically. It's going to be more local from more kind of the eye-based symptoms.
Thank you.
Yeah. So one of the big questions that I know was asked to me earlier is, how will this change? How will this technology change what we're doing currently and where we're going forward, whether it's for the provider or for the patient? And so the big thing for us is early and differential diagnosis. So a lot of times patients come in to see us and they're complaining of problems and we can't see them. And so we have to wait until their disease manifests and impacts them so much that now we see it. And so anytime that we can use something that can see something smaller that we can't see in any type of technology, it'll allow us to see it sooner. And then the big thing that I know our company is looking at with different research is, are eye movement patterns different is eye motion different in different disease states? Can you differentially diagnose them? And there's a bunch of studies going on across the country looking at eye motion differences in different disease states. Because a lot of disease states that have eye movement problems, for example, Alzheimer's and Parkinson's, pathophysiologically, those are different conditions. And so theoretically, they should have different eye motion problems. And so it's taking a look at the eye motion metrics and seeing, can we look at those pathophysiological differences using an objective biomarker, and then quantify the progression over time. Right now, a lot of times, just in general disease states, a lot of times we're using maybe an MRI. And I know in eye care, a lot of times when we have a patient where let's pretend they have optic neuritis, so they have inflammation of their optic nerve, they get vision loss, they come to see an eye care provider, and we send them for an MRI. We know that with the optic neuritis treatment trial, a lot of our patients will have a normal MRI, but within a few years, that MRI will become abnormal and they'll get MS. Not every single patient, but a lot of them. And so it's frustrating because what that tells us is the MRI is normal now, but it's not small enough to be able to see things for everyone. And so that's the cool thing about technology is as technology gets more accurate, we'll be able to help patients more. And be able to see when changes happen more. And it'll be really cool to see the role of eye motion in that, because the eyes are I always say it's, the only internal organ that's facing the world. And so you can kind of get a lot of information from the eyes.
So increasing that sensitivity of our technology maybe leads to earlier diagnosis, which leads to earlier treatment. And I think that is always the long-term goal, and that's helpful. Very helpful. Hopeful.
So, and then to not talk about disease states, the other thing that we've looked at, so this was actually a study I did when I was working at UC Berkeley, and we looked at fixational eye movements in elite level athletes. So that question of, can you see the ball better? And so we took a look at elite level baseball players and compared them to age matched controls. And what we found is their fixational patterns were different. And so I always say, imagine that someone's releasing a baseball at the plate. When an average person looks at the baseball while they're trying to, they're deciding if they're going to swing at the mound, even though they think they're fixating stably on the ball, on average, their eyes are moving and they're moving about the width of the ball, which you can see over on the right, about how big in the red, that was kind of how big their eye movement discrepancy is when they think they're looking at the ball. But the elite level players, their fixational pattern was the size of the seams. And so they are fixating way more steadily on the ball than the average person, which was pretty cool to look at. And I know we've done a couple of other studies looking at how fixation is different in elite level athletes. And that would be, always interesting to see are they a great athlete because they have good eye movements, or is being an athlete give you good eye movements? And I think that's something that sports performance always looks at for sports vision, which is a cool area of research as well.
Shifting their baseline or their normal as an elite athlete is going to help us treat these people post-concussion or mild TBI, because they fall into normal limits. But we have to remember, they started way at a much higher level. Their normal, their baseline, right, started at exceptional. So we have to have that. Otherwise, we've been discouraging people by just saying, you're falling within normal limits. Well, not for what they need to be able to do and what they could do before.
Yeah, and such an excellent point, because there's so many times where, we compare people to age norms, and the problem is that, age norms isn't necessarily where you used to fall. And I always say, if you're working with a patient, you treat them as an individual. We look at studies to look at science and how we do treatment paradigms based off of group work in clinical trials. But when you're sitting there with your patient, you don't comparing them to age norms isn't always helpful, as you mentioned, because at the end of the day, I'm trying to get them to where they were, what they think their normal is, not what I'm telling them their normal is. Because if a patient comes in, whether it's, and we know that with cognition too, where someone comes in, they're a high level CEO, and you're like, oh, well, your testing is that of an average human. And you're like, well, that was a high functioning CEO. They probably weren't an average human. So same thing with the eye movements. Everyone's eye movements are going to be a little bit different. And so finding that baseline can be hard. So this is some of the early work that our CEO did. So she designed the device when she was at Berkeley. I worked with her when I was at Berkeley as well, doing research in athletes. And then she did her postdoc actually at UCSF. And they used the Retitrack technology, so the tracking scanning laser ophthalmoscope, in patients with MS. And what was cool about it was that they were able to use the microsaccadic dysfunction as an objective measurement for MS disability level and disease progression. And what's neat about that, for those of you on the call that don't know, currently the EDSS is the disability score used for patients with MS. And it's done mostly based off of patient reporting, but mostly it has to do with their mobility level, right? So are you able to walk on your own? Do you need a walker? Do you need a wheelchair? Are you in bedbound? And it kind of goes down from there. But there's a lot to disability level with multiple sclerosis that is outside of that symptom score. And so if we can find something that's more objective, that can kind of show granular changes, it'll be really impactful per patients. Being able to objectify that subjective symptom score would be huge. We've also, next slide, done some research. Go to the next one, in concussion. And so what this was a study that was done at University of Pittsburgh looking at fixational eye movements in kids age 12 to 27 with a recent concussion, and using fixational eye movements, they were able to show concussed from healthy control, which is huge to be able to differentiate healthy control. And then there's also been some research looking at, can you use eye movements to prognosticate or predict how long someone's concussion may last? And so there's a lot of research going on right now in that realm, using the eye movements as an objective biomarker for recovery. We know a lot of clinical studies in ocular motor movements and vestibular ocular motor movements have shown that eye movements take longer to resolve. And so patients' symptoms can improve, but they still have some vestibular ocular motor impairment, and ocular motor tends to be one of the last things to get better. So from a diagnostic, it's great for that return to consideration, because one of the problems, right, balance is a great way to diagnose concussion on the sideline, but balance gets better pretty quick. And so you can't use it necessarily for the entire duration of the disease state to make those decisions for return to learn and return to play and return to work. So there's a lot of research going on right now looking at eye movements as a way to kind of help objectify that process.
Are they using eye movement measurements to baseline athletes at the beginning of the season and then compare if they were concussed to retest?
So depends on the study that you're looking at. So I was just kind of talking generally about eye movement research in concussion. Some of them are doing baseline exams. Some of them are not. And so it just depends on the study that you're looking at. But that's where a lot of them will just look at, if they don't have baseline measurements, looking at age match controls to be able to kind of differentiate them.
I want to make sure that people who are asking questions in the chat, just hang on a minute. We're going to get to your questions in just a minute. Stay with us, and we're going to almost through with the slides, and then we will entertain your questions.
Yep. So, and then this was kind of what I was talking about. So this was a poster that was presented last year at the American Academy of Sports Medicine, showing that fixational eye movements actually were a very good prognostication predictive for how long the concussion was going to last. So meaning if your fixational eye movements are worse at post-concussion, your concussion is going to last a little bit longer than someone who's not. So being able to tell someone, which I think is really helpful, this concussion might last a little bit longer. And so it'll be interesting to see where the data goes to be able to see, can we predict? Because that's the hard part right now is when someone gets a concussion, you're like, well, and you kind of put your arms up and you're like, we'll see how long it takes for you to get better, which is kind of torture for patients of like, well, maybe it'll be next week, maybe it'll be 6 months from now. And you can't plan your life around not knowing. So I think I think prognostication is something that's really needed in concussion management. It would help everyone, I think, both provider and patient.
Absolutely.
So, and then this was kind of a question that was asked was, what's the benefit for the patient? I think the big benefits are you don't have to be dilated. I know every time you hear retinal scan, you think, I don't want to be dilated and I don't want an air puff. You don't need either of those. It's a fast scan and it can be kind of helpful to quantify some of the symptoms that we might not be able to see. So it's kind of seeing the unseen and being able to objectively monitor it over time. So with that, I'm happy to take any questions that you have.
So we have had many questions in the chat. I'm going to start scrolling up through them and give them to you as I see. Okay, so Elizabeth asked if there's any treatment for oscillopsia that is caused by an acoustic neuroma. And I know you mentioned that oscillopsia can present with Alzheimer's and Parkinson's. Mm-hmm. Is the treatment for oscillopsia something that is you can approach regardless of the cause, or is that something that would be specific to the underlying cause?
So when you're looking, in our clinic, we always say when you're treating, you don't treat by chasing the symptom, you treat by chasing the symptom generator. And so oscillopsia is the symptom. I have symptoms that the world is moving around me, and we have to figure out why you're getting it and where it's coming from. And so, for example, with an acoustic neuroma, some patients can have issues where it's pushing on, a nerve that's causing dry eye or something like that. And so treating dry eye can make people feel more stable. Not that dry eye is causing oscillopsia, but it can definitely influence that blur component of it. A lot of times the acoustic neuroma, as an eye doctor, I will say I see a lot of patients with acoustic neuromas more for the dry eye component that comes with it if it gets too big or after it's been surgically removed. And the dizziness component or the oscillopsia component that comes with it, I'm usually sending to vestibular PT because it's usually impacting more of cranial nerve 8 or some of the hearing impaired issues that come with the location of the tumor. And so for me, I'm usually consulting my ENT colleagues or my vestibular colleagues.
Thank you. So another question we have in the chat here from Natasha. She says that she knows that caffeine and sodium affect her vestibular system relating to her ears and the vertigo that she feels. But is there anything that we consume that might impact our eyes and how they talk to our brains?
So nutrition definitely has an impact on our eyes. And so we know that eating fruits and vegetables are great because they have a lot of carotenoids that can, the back part of the eye, the macula, has a lot of pigments in there, and they come from fruits and vegetables. And so eating a balanced diet is great. And we know that can help if people have dry eye. So why I get so into dry eye or blurry vision is when you have a vestibular component, you're going to be more dependent on your vision to hold your balance. And so the more that we can maximize your vision to help you out while you for me, it's always working with a vestibular person at the same time to see how we can get the vestibular issues back for you. But if not, it's how can we optimize your vision? And so making sure that you have a clear surface with and we manage any dry eye that can happen, making sure that you're in the right pair of glasses. It's not going to cure your vertigo, but it will help you in the sense of allow you to have a better sense of balance by allowing you to rely more on your visual sense when you can.
I have a
That makes
question.
sense.
How many Retitracks are out there, and how likely is it that someone will experience one or get to be tested or see one in a clinic?
Yeah. So as of right now, we were FDA cleared as of last year, and so we will. I would have to ask our CEO how many are exactly out there because that's not my area of expertise. But as of right now, we definitely have at least 14 in clinical research centers across the country. So we're doing mostly research. And just remember that kind of everything I've talked about so far is very much based off of research. And that we haven't been cleared for any disease states. It's not a diagnostic for a disease. The Retitrack itself is really just used for the ability to monitor fixational eye movements and the eye movements we described before that are kind of invisible to see.
Okay, good. So we're talking about things on the horizon and opportunities for hope and things that will be may become mainstream or a part of a comprehensive neurological and balance center in the future as we understand the unseen eye movements. Okay,
exactly.
Great.
So we have another question from Lemore. They ask, could ocular instability be interpreted as or related to cortical visual impairment?
So for the audience out there, and I'm going to take off my CMO hat and put on just my optometry hat for these questions going forward because they're all clinical. And so I do want to differentiate that for everyone that I'm not speaking on behalf of C-Light. I'm speaking on behalf as being a clinician right now. So for those on the podcast, what is cortical visual impairment? So cortical visual impairment is a condition where you can't see because you've had damage to the brain and the brain's ability to process what it sees, but the eyes themselves are fine. And so there is no research right now on fixational eye movements or a lot of ocular motor eye movements in CVI. However, that being said, if we go back to that first slide where I said the whole point of eye movements is to point your fovea at things. It is not uncommon when I've seen kids who've had CVI that they really don't have eye movements at all because they don't see. So there may be hand motion vision. Sometimes they're 2400, but their vision is so bad. And that's one of the kind of factors in kids with CVI or people who have cortical visual impairment is that you will present something to them and they'll grab it without moving their eyes. And it will really terrify the parents where they're like, I could put an apple in front of them and they'll grab it without looking at it. And technically their peripheral vision sees as good as their central vision. So they don't need to look at the apple to grab it because they don't need to move their eye to see it. And so it's kind of that education of, can CVI impact ocular stability? Most likely because that feedback loop is going to be dependent on visual acuity. And we know CVI is going to impact visual acuity. Are there any tests out there, diagnostics or clinical trials out there that'll say that? Probably not. So the research is really limited as far as being able to test eye movement in those kids. And because CVI, every case of CVI is different, which does make it really hard to make a generalized kind of statement about that group as a whole.
Okay. Another question that we have is from Joe, and he's curious if fixation eye motion is also the most unbiased eye movements for animals as well, if you know this.
I have no idea.
I
would have to depend on how good a vision they have and how their retina is developed, to be honest. So for example, like rabbits have a different fovea pattern than humans do. And so their eye movements are actually different than human eye movements because their retina is different than human retinas. So it would depend on the type of animal, and then it would depend on kind of how their brain evolutionarily has decided it wants to use its macula and how good its vision can be.
When you have a patient who gets diagnosed with oscillopsia, or that's the presenting symptoms, what do you feel are the most effective treatments for oscillopsia? And do you think that as we get better at identifying and diagnosing it, that the treatments will improve as well?
So for me, and that's a huge, again, clinician hat, not my CMO hat. Oscillopsia to me is a symptom, and I have to figure out where it's coming from. Is it coming from the ears? Is it coming from the brain? And then if it's coming from one of those, why is it coming from there and how do I treat that? So if it's coming from the ears, usually I'm sending it to an ENT and a physical therapist. If it is from visual instability, I have a occupational therapist in my office, and we do a lot of vision rehab for stability for the ocular motor system. So we know that accommodative and convergence instability can cause ocular instability. And so working on accommodation and convergence can be helpful. I think one of the most helpful things for people, which is not talked about enough, is getting them out of progressive or bifocal lenses. So progressive lenses have inherent distortions on the edges of them, which allows you to essentially, it's like a way they grind the lens. And a normal person who doesn't have oscillopsia doesn't see the blur and it doesn't bother them. But when somebody has a vestibular condition and they're wearing a progressive, they're more visually dependent and they see that blur, and their brain will actually be more dizzy in a progressive. And so one of the big things that I do to help patients is I take them out of progressives and I have them wear a pair of glasses just for distance or a pair of glasses just for near. And that it takes a lot of their symptoms away. It doesn't fix their problem, but it takes away a lot of that exacerbation that they don't realize is happening with their progressive lenses. So I think that's a big one for me of, there's never going to be one thing that's going to treat all oscillopsia, but all patients with vestibular disorders pretty much have trouble with progressive lenses. So that's one thing that very kind of, no matter what's causing it, I can at least make that feel better by taking them out of that progressive. That's been a big one for people before, where they're just like, oh, I feel so much better. Like, it's not gone, but it's like, oh, I feel it's definitely just not worse. I think that's the best way to say it.
And for the audience to understand, I think what you're saying is, that it is reasonable, if you are experiencing oscillopsia, that you would be given some eye exercises to help with vergence, convergence, saccades, smooth pursuits, all those things. So it's reasonable that eye exercises would be a part of your rehab program, given a symptom like this, right? That's what I was trying to say. And you send out for that, and hopefully more and more optometrists and ophthalmologists will recognize that there is some positive impact or result from oculomotor exercises. I always used to say 30 years ago, they're skeletal muscles wrapped around your eyes, so let's exercise them, but I think that everyone doesn't appreciate the potential benefit of eye exercises that are prescribed. So I think it's good for the audience to hear that. We have a global audience, and eye exercises aren't readily, available and given.
Yeah. And I think, it's always hard because, so ocular motor therapy, or orthoptics is what it's called, vision therapy. There's been a lot of improved research in that in the last 5 to 10 years, showing that doing eye movements can be helpful for things like convergence insufficiency and accommodative insufficiency. And we know that with a lot of patients doing ocular motor rehab and research, especially there's a lot of research right now in concussion, I think that's going to shed a lot of light on the help of doing ocular motor exercises and helping that. Because I think right now it's a very controversial topic for people, as far as, does it help, does it not help? And I think that's where I think the science is going to help a lot. And as we start to learn more and we have tools to show, right? So, if we have an objective measure, we do the rehab and the objective measure gets better along with the subjective complaint, that, it's pretty irrefutable at that point. So I think that's where having better technology to objectify the eye movements and show improvement will really help validate that research and that therapy.
Absolutely. I know we're at the hour, and this has been a very, very amazing conversation, highly scientific and detailed, but one that it's great to learn about the new frontiers in vestibular medicine and ophthalmological medicine, I guess you'd say, vision medicine, things for diagnosis and treatment, and the research that gives us hope to have an opportunity to get back in balance again with our eyes and with our body. And this conversation with you has helped us make vestibular visible again in a new way that we can see better, so we can help people with dizziness and balance disorders. Is there any final thoughts? I want to make sure that you're able to direct people to your website and that you're able to tell them how to find out more. If there are people who are watching, again, like I said, from all over the world, who may have institutions of higher learning or academic clinical research that may want to connect with you guys.
Yeah, so our website is sealighttechnologies.com, and you can just go to the website and you can look at some of the retinal videos that we do already have online. And then if you want to contact us further about research opportunities, or if you're interested in the device because it is cleared and billable, by all means, just let us know.
Thank you so much. It was great to have you all, and I look forward to seeing what happens next with everyone and with this work. And if you're joining us, we thank you again for watching and tuning in to Making Vestibular Visible. Good night.
Thank you, Jacqueline.
Thank you.